This is Dana Dunleavy back from Buffalo, New York. Lucky to be here with Blake Parsons. You mentioned at the beginning, but you're a vascular specialist. You're not really looking for patients with failed back surgery. And, one of the wonderful things I think we've found, right, is that, failed back, depending on the study we look at, responder rate about 60, 70%. Painful diabetic neuropathy, really looking at a responder rate of over 90%. What are your thoughts on that?
Yeah, it's been great. And maybe I'll start with a little bit of like, how the heck did we get here, meaning me in this practice? So to your point, a large part of my practice is vascular, so both PAD and venous. Like I said earlier, I have 3 vascular surgeons. So we have a really big, and we have 5 cardiologists, and they don't do any PAD. They're cardiology only. So we have a large vascular practice and a large amount of patients that come through our clinic. So these patients, we have them, right? They're vasculopaths. These are all patients who have diabetes. They're coming to us. And so what we would see is, me and my partners, is we're seeing these patients, and yeah, we're working them up for their claudication or whatever else. But their biggest complaint was always their peripheral neuropathy. My feet are numb. They're on fire. I've got burning pins, needles. I can't walk. I feel unstable. I can't feel my feet, and so, we've kind of eventually were like, well, what all is out there? Like, they act like there's no options essentially for them other than take gabapentin or Lyrica. And if that doesn't work, see you later. And so that's kind of how we started looking at the space. And then since I'd already done these permanent stims for back pain patients for another couple of guys, it was kind of an easy transition as we started to look into it. And then all the recent data that's come out recently, specifically for diabetic neuropathy, it just kind of made sense. So we actually started a neuropathy clinic at our facility, and it's run by one of our nurse practitioners. So I just work them up myself because I'm doing it. I'm used to what needs to be in the note and everything. But for all my partners, they will send these patients to our neuropathy clinic. And so then that way, the patients make sure that they're optimized. They've tried all the medications. We're trying your gabapentin, your Lyrica, your amitriptyline, duloxetine, whatever it is. They've done capsaicin patches, whatever. Insurance requires that they have at least failed 2 conservative therapies, and that's all that they have. So there's not like back pain where they need to have done, epidural injections, physical therapy, surgical consults, MRIs, all these different things that they have to go through from a back pain standpoint. You don't have to do that with peripheral neuropathy. So that makes it a lot easier. And obviously, not every peripheral neuropathy patient we see is going to need a spinal cord stimulator, right? Like, every patient will tell you that they've got 10 out of 10 neuropathic pain. You say, oh, okay, well, there's this option. As soon as you tell them, some of them, about spinal cord stimulator, like, you know what? It's not too bad. So you find out real quick who's really in significant pain and who's not. And there's some people, they do fantastic on gabapentin or Lyrica or whatever the medication is, or they get significant enough relief that they're happy with the results and their activities of daily living is much improved, and they just go on with that. But we've now streamlined the process so that if these patients do fail, we already have everything that we need to submit and move forward. And so it's essentially we're just capturing all these patients that we already had coming through the clinic. So we don't even do any advertisement at all, which I'm sure that most places out there, just like the state of Oklahoma, where these neuropathy clinics have popped up everywhere that are primarily neurology owned. And so they're doing a lot. There's lots of advertising, lots of patients going through those as well.
A lot of great things you just mentioned, but, one is the neuropathy clinic. That's pretty cool. One of the discussions, if we think about your group of kind of OEIS people, right? You have cardiologists, vascular surgeons, interventional radiologists. The initial, I think, concern with this is, yeah, I see a tremendous amount of diabetic neuropathy in my clinic, but that sounds pretty difficult to manage medications. So, to your point, you kind of have a basic sheet of what these classes are. It sounds like you have your go-to of your 2 classes.
Yeah, and then we'll try all different things too. Like I said, there's all kinds of stuff besides if they fail Lyrica. So Lyrica you have to write as a scheduled, which is goofy, but it is what it is. And then, we usually start everyone on gabapentin. There's obviously a high rate of, oh, not complications, but side effects with gabapentin, most commonly being sleepy, tired. Some people, you really have to watch it in older people and what you're giving. I don't ever start them off with more than 100 milligrams at night. And even most of the time, it's hard for them to tolerate that. And then try Lyrica, but amitriptyline, those are other options. A lot of the SNRIs that are out there you can try as well. So there's different drugs, but like I said, you technically only have to try 2, and most of them will tell you they're tired of taking pills and they don't like the side effects from them, and what else can we do?
Yeah. For me, it's usually, I have to go back in time with these patients, right? And just see what they've already discontinued because most of them have already tried multiple classes.
Yeah. Well, that's the beauty. I mean, to be honest, most of the time, by the time they see us, they've already tried more than 2 drugs, so it's just the people who haven't had anything and we've got a lot of rural America out here, and so a lot of them don't have access to a lot of healthcare, haven't been undergoing a lot of management, or they're just, good old boy farmer out there. They don't want to go to the doctor ever. But so they've come to you and they haven't had much of any kind of workup. But to your point, a large portion of them have already undergone medical management and failed it.
And, some of the interventional radiologists have wondered, how do you communicate with vascular surgeons, about this since, probably the predominant, vascular patients across the country are still with them. My experience has been you just tell them that they can refer the patient. They don't have to do any management. Your thoughts?
Yeah, I mean, obviously, I'm in a little bit of a unique situation because they're my partners, but for people that are in a IR specific group, and obviously there's probably a little bit of conflict between other vascular surgery groups. It's just about them having a trust level too. I mean, what I could see them having the biggest problem is, hey, if I refer you this patient, am I going to get the patient back? And for fault, because inevitably they probably got underlying peripheral arterial disease that they're following as well, right? So that's just going to have to be a relationship that you build with that group and see if that is something that works. I think that's kind of the beauty of our group that we've been able to do, and it's a lot of the now kind of groups that we've been a part of around the country is trying to have a true multidisciplinary approach where you've got multiple subspecialties together to try to work together and not necessarily kind of compete, with each other.
And again, with your neuropathy clinic, I think that's pretty common in our specialty to say, hey, we have like a vein night, right, where people can come in for free. Or maybe you just have so many patients that it's just a clinic. Have you found that this has worked out well offering a neuropathy clinic?
Yo, yeah. So when we first started, it was like an explosion because, for people that have had practices going for, say, there's plenty of outpatient vascular practices out there that have been going on for a long time. Well, you now have a large volume of patients. Well, with any EMR system now, you can essentially go in and screen every patient that's on gabapentin, Lyrica, amitriptyline, whatever, and it's going to bring you up a giant list. So you now have just flagged essentially every neuropathy patient in your clinic. So now every time that patient comes in, or you send them an email or a mailer or text or whatever, you can now say, hey, how's your neuropathy? Okay, if it's not under control and it's really bothering you, then we've started a neuropathy clinic. If you would be happy to be involved with that, we can set you up. So that was a really basically just went from 0 to 60 right out the gate because we just all had this huge influx of patients. And then now, since that's been going on for several years, we still luckily have such a influx of new patients all the time that we're able to be there. And now since we've been doing it, word kind of gets around and from our referring physicians as well. And so they've obviously been trying to manage these patients, even podiatrists that are managing them, and they can't get anywhere. Then now they're starting to send them to us specifically for the evaluation for spinal cord stim.
And, with that and some of the referrals you're getting from the community, can you speak at all to American Diabetes Association or endocrinology recommendations?
Yeah, so they've both been over the last year or maybe 2 years, I think they've all been forward on saying that this is a valid option, especially given the new data that came out, over the last year about the 10 kilohertz data and showing the significant improvement, not only in patient satisfaction and decrease in their pain levels, but there's even a lot of data, like there's a paper out by Chen showing, now it's a very small subsample, showing that there's increase in nerve fiber density when they do punch biopsies. So now there's a big look at that as to why is that, are we actually improving their sensation by increasing their nerve density? Touch. So, filament tests on these patients have been shown that significant improvement in their numbness in their feet, which we can go on and on about. Not only are you improving their pain, but the other beauty, and I'm sure we can get more into, of this whole procedure is how else are we improving their quality of life and risk factors, right? So all these patients are for the most part, not all, but most patients, they're diabetics. So, they can't feel their feet. They're unsteady. They're older patients. They're complaining all the time about balance issues. Well, after they've done the trial or the perm, that's almost one of the top things they'll tell me is, oh my gosh, I can walk out of my house on my yard and I can feel the grass and I don't feel unsteady. I can walk. So, you know, at what percentage are we potentially saving these people from fall risk and broken hips and these type of things? On the other hand, on the flip side, from the PAD and vascular standpoint, if they now have better improvement in their sensory in their feet, how much are we now decreasing the risk of diabetic foot wounds because, they're trimming their toenails and now they can actually feel the tip of their toes, or they're not scuffing their foot on the ground when they're walking, or their grandkid throws a Lego in their shoe and they can actually feel it instead of walking around on it. So these are all kind of I think the future things that we've got to tease out that are really neat in the space about actually improving the quality of life more than just pain.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BacktableMSK on Instagram, Twitter, or LinkedIn. Backtable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Junroy Kennebrew.
Thanks again, and see you next time.